morning, and thank you, Prof. Noran and Prof. Victor, for your excellent talk. I'm Dr. Thong, and now moving from climate health and impact on our care of patients, we'll move on to genomics and to genomic medicine. So I'd like to introduce our next speaker. She's none other than Dr. Tae Soo Koon, a pediatrician and a senior lecturer at the Genetics and Metabolism Unit, Department of Pediatrics. As most of you are aware, the genomic age is here, and clinicians are actually very interested in trying out some of this new genomic testing. This morning, Dr. Tae will be helping you to answer a very important question, and that is whole exome sequencing, or in short WES, the answer to end the diagnostic odyssey in rare diseases. So without further ado, let Dr. Tae give a talk now. Dr. Tae?
Thanks, Prof. Thong and UMHealth for us to share on the topic is whole exome sequencing, the answer to end the diagnostic odyssey in rare diseases. Right, so a little bit on the outline that today I'm going to share on the overview on rare disease and the diagnostic odyssey. What is whole exome sequencing? Its diagnostic yield, cost effectiveness, possible result, and secondary finding. The importance of genetic counseling, especially the pre-test and the post-test counseling. Share a little bit on our local experience and end with a discussion and conclusion. So rare disease is the illness that affects a small percentage of the population and is frequently debilitating. It is estimated to be roughly around 6,000 to 8,000 rare diseases worldwide, and the numbers is growing with the advancement on the genomic sequencing testing. However, there is actually no single universal definition on rare diseases. And for example, United States is actually taking, according to their Rare Disease Act 2002, they define rare disease as the prevalence of below 1 in roughly about 1,500 people, and where else in Europe, according to the European Commission on Public Health, they're actually taking the prevalence at around 1 in 2,000 people. So in 2015, they actually looked into these definitions of rare diseases and came up with a prevalence threshold of global average of around 40 cases per every 100,000 people. How about in Malaysia? We do not really have a rare disease national registry. And according to our Malaysian Rare Disease Society, MRDS, we define rare disease as a disease incidence or conditions that happen in below 1 in 4,000 people. However, our Ministry of Health actually taking the overall prevalence at about 0.65% to 1% of the population with a complicated diagnosis as well as treatment. Even though individually they are rare, but collectively they do give a very high impact on health, mortality, as well as morbidity. For example, little congenital malformation remain the second most common cause of death in our under 5 population. And rare disease is very difficult to diagnose, and often there is always misdiagnosis because of the heterogeneous in view of the clinical presentation. And there is inadequate local data and does lead to lack of awareness and exposure among our healthcare providers, with inadequate expertise as well as laboratory support services, and seldom this topic is discussed among our policymakers as well as the general public. So a diagnostic odyssey basically just means a protracted journey towards the diagnosis of people living with rare diseases. It is estimated roughly about 50% of patients with rare genetic diseases actually never receive their diagnosis in life. And of those that receive the diagnosis, about 25% taken an extended time to reach the diagnosis, roughly ranges from 5 to 30 years. And of that, about 40% of misdiagnosis. An accurate genetic diagnosis is very essential, especially for informed care for the patient, for their precision management, as well as the surveillance, and informed genetic counseling for the family members in terms of the recurrent risk, as well as the prenatal genetic counseling. So let's just walk through the technological advancement throughout the years. Way back in 1950, that is the first time that we discovered human chromosome consists of 46 chromosomes, and they are the test called conventional karyotyping. And from there, about 20 years after that, we noticed another technique called fluorescence in situ hybridization, FISH, which managed to identify a smaller changes in the chromosome, for example, those microdeletion and microduplication. And at the same time, people started to sequence the gene via the technique called cellular sequencing, but it took very, very long to just sequence one single gene. And in around 1990s, there is, based on the concept of FISH, they actually developed a whole genome kind of test called chromosome microarray analysis, where this test resemble a very high resolution of the karyotyping. So it managed to identify copy number changes and more microdeletions as well as microduplications. And the real paradigm shift really happened at around year 2000, where a new technique called next generation sequencing introduced. And this is where they managed to actually sequence in parallel multiple segments of the gene, and thus really had a lot of cost as well as time. And that is where this targeted gene panel, exome sequencing, and even a genome sequencing is made possible. And what is actually a whole exome sequencing? Before we go into what is whole exome sequencing, let's just touch a little bit on what is the basic of our genomic. So if we imagine our genome like a book, so we actually have these two volumes of the book. One volume comes from the mother and one volume from the father, and that is our genome. And in this book, there is 46 chapters, which is the chromosomes. And we roughly have about, till date, 20 to 25,000 genes that is identified, and it's resemble the pages. And in those genes that we have the words, which is the triplets, as well as the nucleotides A, T, C, G. I believe everyone still remember that, and that is the letters. If there is any change in the letters, we call that a genetic variant. And the exome is actually roughly around 1 to 2% of the whole genome, because exome is the coding area of that code to the protein, and there is also a non-coding area called intron. So if we look into the size and what is a test that will be able to identify this, then the chromosome is actually roughly identified about 100 million bases, and we could use a conventional karyotyping to identify that. And with a higher resolution microarray testing, we could actually identify copy number variant, which is ranges about 30,000 to 3 million bases. And with sequencing, we could able to look into a single gene, which is about 3,000 bases, and sequence even up to one base change. And to make things easier to comprehend, actually, I put it in this table. And how about the diagnostic yield of this whole exome sequencing? It's really very much depending on what is the indication for the test. When is the timing of the test done? For example, throughout the diagnostic trajectory, in which time point is the test done? Whether is it as the first tier test, or is it as the end, approaching the end of the diagnostic Odyssey testing? And also, whether do we only do the test on the proband, which is the singleton, or the test was done on the proband as well as the parental, which is called a trio. So in 2016, Ratero and the colleague have actually looked into the clinical utility of whole exome sequencing across a few clinical indications, and the overall diagnostic yield in their studies revealed about 28%. And the diagnostic yield actually increased when there is a trio test done, which is like done on the proband as well as the parents, up to about 30%. And most of the time, the indications of referral will involve abnormality of the nervous system, followed by multiple congenital anomalies. And if we look at the diagnostic yield according to the indication, for their studies, they actually identify here that about 55% diagnostic yield in any hearing impairment, and 31% of diagnostic yield in CNS manifestation. However, in their study, they actually separate CNS seizure as well as peripheral nervous system separately. And I believe if they make it in a accumulated way, they will be we have a higher diagnostic yield. As a lot of other studies basically based on a neurological indication, the diagnostic yield is about 40 to 50%. How about the cost effectiveness? This is a study looking at the cost per sample as of 2020. However, I must say that this cost doesn't really imply to our country, as we do not actually have in-house whole exome sequencing testing for the moment yet. And there is actually very limited real health economic-based study identified, and most of the study actually focus on utility of whole exome sequencing in neurological and neurodevelopmental disorder. And we can see that actually with time, the whole exome sequencing costs have dropped drastically with the amount of tests, that is increasing amount of tests done. And this study done in 2018, they actually quote the cost as per the year of 2018, and now actually the cost has been dropped by then. And in the more latest study in 2022, they actually identify efficient and cost-effective of the whole exome sequencing in a progressive neurological disorder. But if they have been done in the early diagnostic path as compared to the end of the Diagnostic Odyssey. And when we talk about all this genomic testing, we need to realize about what is the possible result that will be identified. According to the ACMG, the American College of Medical Genetics, the variant or the change that we identify in the gene can be categorized into 5 categories. And of clinical utility, those pathogenic and likely pathogenic variant can be used for direct management, family planning, as well as for predictive testing. And there's always this large group of variant that always cause a lot of headache for those that send this genomic test before, which is called the variant of uncertain significance. This is a group of variant that they actually can't really identify whether can it cause the condition or it is not fall into the categories that it is benign. Thus, whether or not to report this group of variant is always in dilemma, and we need to always remember that this type of result cannot be used for family planning, predictive testing, or any segregation testing. Some lab then further subclassify these VUSs into 3A, 3B, and 3C, where 3A is more potentially pathogenic and 3C is more potentially benign. And there is always a different reporting criteria for each and the lab, and some only reported 3As, but some actually even reported 3C. So we really need to beware when we're sending for all these tests. And another things that I would like to highlight, and which also bring a lot of issues, is the secondary, or what we call the incidental finding. ACMG actually came out with a recommendation that there is a list of around 73 genes which is medically actionable that we will need to report on that. However, again, different lab, they will, based on their different guidelines, beside the ACMG, some lab will actually even reported on the carrier status, but we need to remember that this whole exome sequencing, or what we call clinical exome sequencing, is actually not a carrier testing per se, and some lab even will report it as a pharmacogenetic variant. So really, we will need to have a very proper pre-test counseling to let the clients or the patients aware about all these implications. So it is always ethical or debatable issues, whether to report it or not, and how much of the things that we should actually report it. For example, for all those that medical actionable gene, for example, it is like the cancer predisposed gene. What we are talking about here is the germline cancer, for example, the BRCAs. When you have the gene, it doesn't, pathogenic gene variant, I mean, it doesn't really implicate that you have to develop the cancer, but it's much, much higher risk. So the benefit of reporting it will really be then they can have a proper surveillance earlier, or even the risk management or risk reduction procedure that will manage to be done. But some clients actually take it as a very distressing issue, which really raise a lot of anxiety and psychological harm in them. And thus, a proper genetic counseling really will tackle this issue. And besides that, there's also sometimes discrimination or stigma, especially in terms of the insurance or employment, as well as we then need to think about, with the limited resources and the qualifications of the healthcare professional, are we ready actually for all the surveillance to be done when we pick up more and more of the secondary finding? And thus, genetic counseling, like mentioned earlier, is really crucial. The pre-test counseling should always include the indication or why is the test done for the patient and their family? What is the potential outcome? I need to highlight the possibility of variant of uncertain significance, as I do have clients that actually will be those that gone through the test without any proper genetic counseling always come back with a lot of questions on the WESs, and they even sometimes make a complaint like, why is that you tell me that you don't know? As a doctor, you should know everything. So it is quite a hard a part for us to then explain to them after the test has been done without a proper counseling earlier. Sometimes there is a negative testing, and we need to highlight to them that negative testing doesn't mean that they do not have the condition. So it is just the condition is still undiagnosed. So what is the cause for the whole exome sequencing tested to reveal negative and with certain clinical presentation? So it could really be, as mentioned earlier, the exome actually only consists of about, actually contribute to about 1 to 2% of the genome. So we still have a lot of intronic region as well as the mitochondrial genome that is not covered by the whole exome sequencing. Or it could be some new gene that wasn't really identified to be disease causing earlier. And we know that this is the clinical testing, and it is not like hunting for a new gene per se. So it might then cause a negative testing result. Other than that, for those that is what we call polygenic condition, for example, like just isolated autistic spectrum disorder or schizophrenia, it is not actually a monogenic condition and thus will not be able to identify via a whole exome sequencing. So other than that, we also need to focus on the secondary finding, the insurance as mentioned earlier, as well as need to inform them that it's always their right to withdraw from the test, even though they have agreed beforehand. So it doesn't mean that if they agreed and then they will really need to proceed with it, as long as in the along the way of the process, if they decided that they would like to withdraw from the testing, so it's actually their right. And also to make them understand about the importance of sharing their result with the family members. But again, this will fall on them, their right. And for the post-test counseling, it's basically involve all the pre-test counseling, as well as then ask them whether are they ready for the result disclosure. You might be surprised that if they agreed for the test and why aren't they ready for the result disclosure. Sometimes we do face these kind of issues, and the clients or the patients actually asking, could we just delay the disclosure process? And after the result, whether it's a positive or a negative result, it always gives a lot of psychological and emotional impact, and thus the counseling or our counselor will give a very good psychosocial support to them. So let's just move on and share a little bit of what is our experience. So we look into a retrospective data of all the patients that was undiagnosed with undiagnosed condition attend to our genetic clinic in UMHealth from year 2019 to 2022, who was investigated with whole exome sequencing. We identify around 232 patients, and the diagnostic yield, overall diagnostic yield from our center is about 39% with a 20% of VUSs. And if we look at the number of tests done by year, we notice that it looked like a very high surge in 2020. That's solely just because we have a collaboration with and research study done during that time. It does. But otherwise, I would say the test per year is roughly about 50-ish tests per year. And throughout this sample, we identified 36 patients with secondary finding, which consists of about 15%. And actually, that is the clients will have the right to decline or to know about the secondary finding. And thus, we need to ask them beforehand. And out of them, there's actually 2 decline to know about their secondary finding. And the test has been done, either a singleton test or a trio test. And as mentioned earlier, we have roughly about 39% of diagnostic yield, but this is like the breakdown of them. For the first line of the testing, we actually identify about 84 positive results, which is roughly about 36%, 53% of VUSs, and 95 cases, which is 41% of the negative result. And then we will need to do a genotype-phenotype correlation again as well as look at all the variant, identify whether do it match with the phenotypes. And throughout that, we identify that there is actually another 6 very high-grade VOSs, and it might be resolved by doing segregation testing or even reanalysis. And true enough that after that, we actually managed to resolve the 6 VOSs, but there is still 47 or 39% of VOSs remain unresolved. And for those that achieve the diagnosis of positive result, we then can move on to do a proper genetic counseling, reproductive planning, treatment, as well as surveillance. And if we look at the diagnostic yield per the primary indication, almost same as any other center, we have the majority referral from a neurology side, followed by congenital malformation. And the diagnostic yields is actually comparable with any other studies, about 40 to 50% for the neurological, and about 30 to 40% for multiple congenital anomalies. I would like to highlight here, surprisingly, the lowest diagnostic yield actually falls on the gastro system and acute liver failure. We seldom get a positive yield for acute liver failure, as well as the interstitial lung disease. And to conclude, rare diseases is collectively rare, but contribute significant to the mortality, morbidity, as well as the healthcare costs. And Diagnostic Odyssey is frequently associated with medical, physical, mental health burden, not only for the patients, but as well as emotional and financial burdens for the patient's family when they are chasing for the diagnosis, do a lot of unnecessary testing, invasive testing, and so on and so forth. And is whole exome sequencing the answer? So it's overall giving you about 25 to 40% of diagnostic yield. Whether or not it is cost effective, I would say that we will need a further study, especially in our own or any other limited resources country, as those study that is available is mainly in the developed country where they have their own technologies for sequencing, as well as a lot of bioinformaticians for the interpretations of the variant. More and more study actually suggest to use whole exome sequencing, replacing multiple panel testing, as well as microarray tests as the first tier genetic testing. But are we there yet? And last but not least, the most crucial things before we do any of the genomic testing is really a proper genetic counseling to make them understand about all the implications. With that, I thank you. Thanks to all your attention, as well as my team member. And a little bit of promo. We are actually the unique Perubatan Genetic in under the Paediatric department buildings. And we provide genetic services for both pediatric as well as adult patients, as well as cancer patients. And you all could just do a referral email to our unique email will do. And this is our unique email and my personal email. Thanks again.
Thank you, Dr. Tay. That was an excellent overview of the title on the whole exome sequencing. We have a few minutes. Are there any questions or any concerns that you'd like to voice out? Please help yourself. Type your questions either in the Q&A or chat box. We have a few questions. We have a few minutes left. Yeah. Okay. Perhaps I can start off by asking a very basic question. Doing this whole exome sequencing test sounds complicated, and you mentioned that it's not available yet in UMMC. What do you think are the resources that are needed to help guide our pathologists or our scientists in UMMC to start this service in UMMC?
Right. Thanks, Prof, for the question. For that, actually, we first of all will need the to be able to done the sequencing, which it is not like a very difficult processes. It's just need a sequencer. But more importantly, we really need what we really need is the bioinformaticians, as well as the bioinformatic variance interpretations expertise. So lately, there is actually a lot of AI to ease this kind of process. Lately, there is more and more kind of AI system that is established to make us be able to do these interpretations faster as well as easier. So I believe if we could actually interpret this AI system together with the bioinformaticians and the clinical geneticists that correlate it with the clinical as well as the variant information, then we will be able to run this service.
Thank you. Yes. Now, another question that has been brought up very often is that should research test results be used in the clinical setting?
All right. Most often because of the lack of services, and then a lot of people then proceed with a research test and use it in the clinical management, which actually we shouldn't use the research result. A few reasons being, number one is the research for us to do this clinical diagnostic testing, we actually need to go through the accredited diagnostic test where they will then confirm the result by another mode of, for example, if the first test was done via and detected the variant via next generation sequencing, then they will actually need to proceed with another mode of sequencing, for example, single sequencing, to just make sure that the variant is at the correct locations and it is not due to the alignment or any other issue that is causing the variant. So one of it is we will need a confirmatory testing, which a research test usually they didn't proceed with that. And then the other things is also because they are not accredited for a diagnostic testing per se, and thus we can't really use it, as the implication is really big where it is not only to the patient but also to the family and the extended family. If you look at it, for example, it could be used directly for the let's give an example, let's say for NF1 gene. If it is noted to be pathogenic, then we will do the surveillance for the patient. But at the same time, we could actually, because it is inherited in an autosomal dominant way, then we could actually give a prenatal counseling and proceed with a prenatal testing. Just imagine if the result wasn't very accurate and then it will affect the fetus's variant interpretation as well, and the implication is very big.
So there is clinical as well as medical legal implications, yeah? Okay, there's a question here. Apart from UMMC, are there any other accredited genetic counseling unit in Malaysia, in the country?
All right. Actually, we do have a genetic counseling master course running in University Kebangsaan Malaysia, UKM, but it is not really receiving the accreditation yet. We are working very hard to get it done. So also we will need to highlight that we actually need the genetic counselor, especially with the more and more genomic testing coming and everyone want to do the test. So the counseling for pre-test and post-test is so important, and we hope that we could actually give them some posts as well as make the course accredited so that we can have train more and more clinical genetic counseling.
Yep, I think there are also other hospitals that offer genetic counseling service now. I think in if I'm not mistaken, Hospital Kuala Lumpur and Penang Hospital. Yeah. Another question here. Great job, Dr. Tay. What is your thought on commercial DNA testing and epigenetic profiling, which are increasingly popular now?
Right. Very good question and difficult question. This commercial DNA test, what are they looking at is actually not really the monogenic variant, but a SNP changes, which is actually what we call a single nucleotide polymorphism. So to date, we actually do not have a very good test or interpretation on these SNP changes, or what we call the genome-wide associated study that is more for all the chronic diseases and not for those that variant in the rare disease. So I would say then they then started to say to talk about the higher risk in developing certain diseases and so on and so forth, which is actually quite hard for us to interpret, especially all this polygenic risk scoring that we are actually not very well established for the moment. It's still under, I would say, the research area, but not so much on the clinical practical use yet. So I always need to tell everyone to take the result with a pinch of salt, and you always need to really not really just take the result and say that, oh, I have these certain diseases, but what do they see as is just a SNP changes and just telling you about the risk scoring.
Okay. Thank you very much, Dorothy. I think we have come to the end of this morning's edition of Breakfast at UMHealth. I think we would like to thank Dr. Tay and everybody else who participated this morning. And we look forward to see you again in the next edition. Good day and goodbye, everyone.